I'd like to welcome you to this edition of the PRS Journal Club podcast with your hosts, Dr. Sammy, Sinno, Amanda Silva, and Raj Sawh-Martinez. Enjoy.
Welcome, everyone, to the October 2016 PRS Journal Club podcast. I'm Amanda Silva, and I'm joined by my fellow PRS resident ambassadors, Sammy, Sinno, and Raj Sawh-Martinez. Today, we welcome our guest discussant, Dr. Devinder Singh, from Ann Arundel Medical Center in Annapolis, Maryland. We'll be discussing an article by Dr. J.P. Hong out of South Korea entitled A New Approach for Reconstruction of Diabetic Foot Wounds Using the Angiosome and Supermicrosurgery Concept. Salvage and reconstruction of diabetic foot wounds can be challenging. For example, major vessels are often calcified and are therefore inadequate recipient vessels. The senior author, J.P. Hong, has dedicated much work to improving outcomes in diabetic foot reconstruction, and one of his concepts is to avoid these calcified vessels and use a supermicrosurgical technique to anastomose perforators instead of large recipient vessels. They're spared by this disease process. The purpose of this study was to evaluate the outcomes using this technique and to consider any risk factors that are involved in flap failure. The authors reviewed 95 cases of diabetic foot reconstruction. They briefly mentioned that patients who needed vascular intervention preoperatively underwent it, and then patients underwent debridement using an angiosome concept where if the wound was involved in part of the angiosome, the entire angiosome was debrided. And then reconstruction was performed with free perforator flaps. The free flaps that were used were mainly superficial circumflex iliac artery perforator flaps, 45%. 22% were ALTs, 10% were posterior interosseous artery perforator flaps, 5% were superior gluteal artery perforator flaps, and there was one case using an anterior tibial artery perforator. The authors briefly mentioned their post-op protocol, which involves routinely using vasodilators such as prostaglandin E1, and that patients are started on wheelchair ambulation on day 4 to 5, compression at day 7, and then they're usually discharged on day 10. If you look at Table 1, it looks at all of the risk factors that they looked at that could affect flap loss. They included age, sex, diabetes type, smoking, immunosuppression, flap size, hemoglobin A1C levels, ABIs, preoperative transcutaneous oxygenation, their CRP levels, CT angiography, which looked at 0 to 1 main vessels versus 2 to 3 main vessels, amputation history, peripheral artery disease, their ASA class status, osteomyelitis, and whether they had chronic renal failure. There were 9 total flap losses and 12 cases of only minor complications. The average follow-up was 43.5 months. When they looked at all of the risk factors that they analyzed, they found that 2 were associated with flap failure. The first was peripheral artery disease with an odds ratio of about 11. However, of note, they found no significant difference between patients who had 0 or 1 major vessels versus 2 to 3 major vessels on CTA. And then the other risk factor that was associated with flap loss was whether the patient had an amputation history with the odds ratio of 9.4. So overall, their flap survival rate was 90.5%. Their limb salvage was 93.7%. And this is comparable to meta-analysis data on diabetic foot reconstruction, which uses the traditional microsurgical technique with a 92% overall flap survival rate and an 83.4% limb salvage rate. So I'd be curious what you guys think about this. I know that a lot of people think that this is great. J.P. Hong's done a lot of research to advance the field in diabetic foot salvage, but some of the criticisms I've heard is that it's really difficult to duplicate what he does because he has this amazing center in Korea where they catch these patients really early, so they're intervened early before they have when at least how we sometimes see these patients with wet gangrene, really bad infections, really bad inflammation. So I'd just be curious what you guys all think about this.
Yes, well, thanks, Amanda. I agree with you. That's a big question. Where in the natural history of this disease does the plastic surgeon become engaged? And as you said, it sounds like in Asia they're engaged much earlier than when we are. Nevertheless, I do have to applaud anybody that publishes a greater than 90% success rate for microsurgery, let alone super microsurgery, where they're basically developing the recipient site as a freestyle. Maybe not. It's almost like the recipient site is dissected out freestyle, and then they're taking the flap. So actually, I kind of thought, they could have used that word freestyle, but of course we know that freestyle means basically how you harvest the flap, not necessarily how you prepare the recipient site. But that's sort of what they're doing. They're freestyling the recipient site, and that I thought was pretty cool.
Yeah, definitely. And I think that, I personally haven't come across any papers yet by J.P. Hong describing this, but I think that would be something that would be really educational for everyone to understand how exactly he goes about finding these perforators and what kind of process does he go through in his mind to find a good recipient vessel. Because I feel like it's not so easy to just do.
Right. Sammy, I know you're at NYU and you guys do tons of microsurgery there. Are you guys doing this concept of super microsurgery and the techniques that are slightly different than microsurgery?
Oh, well, I guess you could say sometimes in the, we did a vascularized joint transfer, and the artery was, we did a point, it was like 0.8 millimeter to 0.5 millimeter anastomosis. So I think there's some times when you would consider it. I can say that I was fortunate to see Dr. Hong operate at our microsurgery course last year, and unbelievably talented. I think there's two things that I think everyone should keep consider when reading these articles and making it look so easy. Number one is that it's not so easy, and he's, as you alluded to, a true master. But number two, if you're going to be attempting, I think one of my attendings brought this up, a lot of times just the way that things are evolving in our practice of microsurgery, a lot of the people that are doing lower extremity reconstruction or committed to it, or foot reconstruction for that matter, are younger faculty members. It's typically the person that is maybe out of fellowship and in the first 5-10 years of their career that are learning how to do these things. And it takes time and nuance to learn how to really do these consistently and effectively. And then by that time, oftentimes people will take on other responsibilities and maybe move their practice wherever it may be, different part of the body. So I think what you were alluding to before, that people really need to be committed. It must be very nice for him to have a center where they can focus on treating lower extremity wounds. I think even at our program where we do a lot of microsurgery, we don't have a lower extremity diabetic wound center of excellence where we sit with the wound team and the microsurgeons come, and we have weekly meetings where we can talk about, okay, when is the best time to intervene? What are some of the options? And I think that's what more centers in our country should do to try to really treat these patients better now that we have these new strategies to do that.
Mm-hmm.
That's a great point. From my standpoint, I don't know what you guys think, but I sort of think of this article, and it's obviously tremendous work, and he's, beyond reproach in his technique. But I sort of see things in themes, right? So, one is getting out of the quote-unquote zone of injury of this ulcer and finding a recipient vessel, like Dr. Singh was mentioning, that is of adequate caliber with good flow, et cetera. And I think we see that in a lot of lower extremity reconstruction where if we have issues, it's sort of choosing that recipient vessel that may be still in this quote-unquote zone where it may not be adequate. And he really makes a big point of, focusing in on that as being, the first big principle. And then the second, sort of optimizing the conditions of surgery, like you guys are mentioning. One thing that I found was interesting, their number of flap losses in smokers and non-smokers was inverse to what, we would think, right? Their smokers had only 2, but the non-smokers had 7, which is sort of counter. So, so I wonder if there's differences, like you guys are saying, also in the population, right? You think your average BMI and comorbidity scale, that would also be potentially different. So how replicable is this study overall? And it seems like they really are optimizing the patient conditions before the surgery. But I think, as far as supermicrosurgery, I think we sort of inadvertently sometimes do that here, not necessarily routinely, but if a perforator is damaged, you sort of are doing this really small anastomosis, like Sammy was mentioning, but the complication rates, I think, are not as good in most people's hands because the other conditions haven't been as maximized as he's sort of describing here in this study.
Yeah, that's right.
Oh, sorry, go ahead.
I was just going to say that's right, Raj. this is not very generalizable, not only because not every plastic surgeon does microsurgery, but frankly, very few do super microsurgery, which is truly a distinct technique.
Right.
And to me, we've all applauded the author for his success rate, and but on the other hand, I can imagine somebody else reading this paper and saying this is overkill, and that maybe the treatment is worse than the disease, or criticizing this paper because there are many other options to choose prior to this concept of supermicrosurgery, that this is just surgical sport, or this is proving that it can be done when we could have done a propeller flap, or we could have managed it with negative pressure wound therapy, or good old debridement and skin grafting. And, all of those could be true, and it really comes back to not the science of plastic surgery, but the art of plastic surgery, which is to say that there are many ways to skin flap. We have a lot of different choices in plastic surgery, and the art of it is balancing the donor site morbidity with getting the wound to heal as fast as possible with as little complication as possible. So I think it's amazing what he can do, but I don't think in my practice I would, because of this paper, change or recommend a supermicrosurgery free flap for all diabetic ulcers at this point.
Right.
Great.
Yeah, I agree. Obviously, it's something that he's a master at, and I think he's more so advancing, kind of in the same realm as when you think of, maybe this is even more niche, but when you think about CPA, like papers that are written on this aren't necessarily saying, hey, everyone go out and try this, but he's trying to advance the field and trying to find an area of, okay, this is a situation where we have high flap failure rates. This is a situation where if we jump to amputation in these patients, there's evidence showing that they do worse. What can we possibly do to push the envelope to, what is there that we don't know that could improve outcomes in these patients? So I think this is a very interesting study in that, moving the field forward and what we're thinking about, but not necessarily like, hey, everyone, let's start doing this necessarily.
That's right. And I think your analogy to VCA is exactly right. It's those people are pioneers, and in some ways, J.P. Hong is a pioneer in supermicrosurgery. Mm-hmm. This paper is a step towards that, so I really applaud him for that.
Yeah. All right. Thanks, everyone. Great discussion.
Thank you.
Thank you.